Welcome, everybody. Thank you for coming and joining us for this next session, which is entitled Assessing Needs, Pathways, and Systems for Implementing Social Prescription in Primary Care to Improve the Health and Well-being of older adults. And just to say that we're representing a very large and dynamic team of young people, faculty, and community partners. Paula will be presenting with me. Catherine is her face is with us, but her voice isn't. She's unfortunately quite ill, but today, and hopefully will, if needed, be able to chime in during the discussion. I'm going to begin by providing an overview, but let me first say that we have no conflicts of interest to declare, no affiliation, honoraria, or monetary support from an industry source to report. So in terms of how we're going to shape this session, I'm going to begin by providing some orientation to our collaboration around social prescription in Montreal and some of the work that we're currently doing to understand community and institutional context, stakeholders, and systems readiness for social prescription. I'll be followed by Paula, who will present an online tool that has been built by communities to facilitate social prescription. And she'll also be showing a short video on that. And then we'll go into some of our research findings using older adults as a use case. And then finally, we'll reflect on the value of implementation research and the designing a social prescription pathway in Montreal and get a discussion going on how to do the same potentially in your context, how important it is to build a corpus of research that supports successful social prescription and its adaptation, evolution, and scale up. So we're here because we recognize the value of social prescription. However, we also recognize that implementation challenges are sort of many. In Canada, I would say we're still at an infancy stage, comprised, of mainly small programs developed in response to local needs, versus a systems-wide approach that aims for implementation at scale, as you find in the UK, for example. Further complicating its further sort of and wider uptake is the need for contextualization across the complexities of Canada's health system. And finally, we also recognize that there are multiple administrative, provider, user, and community service barriers that we need to take into account in design. So in order to enable the potential of social prescription to address the social determinants of health, its design must engage and address the unique needs, goals, realities of vulnerable populations, as well as community health and social sectors. So I'm just going to give you a little piece on implementation research because maybe some of you aren't familiar with it. And this is what we are undertaking, implementation research, which focuses on identifying behaviors, strategies, and characteristics of implementers and beneficiaries and systems that support intervention, sort of implementation, access, use, and impacts in real-world contexts. Implementation research is important in social prescription design because we are seeking to understand what will work within real-world contexts or usual practice settings with attention to those who will be using the research. We consider interventions at multiple levels, practices at the individual level, programs, policies, and often use models and frameworks to help us do that. And we, in the context of this research, use one of those models. It's important to facilitate understanding of context, to assess performance, and to help organizations develop capacity to learn. This is really central to implementation research. And then the focus on the how, the why, and the what is being implemented, and the effects as well of implementation. And then, finally, the utilization of multiple methods, qualitative, participatory, as well as quantitative. So our initial implementation research question was the following: how can a feasible social prescription pathway be designed that links health and social sectors? Related to this are what challenges do community organizations face in providing services to address the social determinants of health? What are people's experiences in accessing and utilizing community-based services? And finally, how can health providers be incentivized and enabled to support referral linkage and follow-up? So our goal in this research was to co-design, adapt, and implement and scale a social prescription pathway for implementation in local and community-based settings in Montreal, and importantly, with our community partners. And Paula is one of them. And as I mentioned before, we do employ the Consolidated Framework for Implementation Research, CFR, to guide the assessment of needs, capacities, and barriers and facilitators to implementation in the setting of Montreal. So this is a rather sort of busy diagram, which sort of shows our initial work, which was funded by SSHRC, Social Science and Humanities Research Council, by CIHR Healthy Cities grant, and then also McGill's Global Health Program. And our first priority in our work was outreach. And that was to really introduce the social prescription model, to identify related practices and barriers, and do this in the context of a roadshow. We presented in front of 4 clinical practices and 4 community-based organizations or networks, taking advantage of existing grand rounds and regular team and network meetings to do so. This was followed by deliberative dialogues, which focused on engaging stakeholders in considering evidence and identifying and prioritizing key components of a social prescription system. In effect, the first part of the co-design system. So, and you'll see through this, our partner, the Practice-Based Research Network at McGill University, the Eva Marston Center for Social Justice and Aging. So our partners were extremely important in this process. We're partway through, but excited about the kinds of discussions and the interest that our work has been generating. So one key feature that was identified in all these meetings was the need for a comprehensive and up-to-date database of available resources and services in the community. So I'm going to hand it over to Paula now, who's going to describe community-based innovation, a tool called Click Social, and why this is a really key component in sort of the development of this social prescription pathway for our setting. So Paula, please.
Thank you, Elaine. So Click Social was an initiative that we started around 5 years ago, and it finally culminated into a platform that helps connect health, community, and social sectors, compile up-to-date information on non-medical resources in a certain territory of Montreal, and it helped facilitate the process of social prescription and follow-up. Next slide. So the context and objective of Click Social was really to highlight the importance of social determinants during the pandemic, which we saw was a need. We also saw during the pandemic, there was a shortage of healthcare and community professionals, and it impacted vulnerable population. So all of this led and gave a momentum to the social prescription initiative in Montreal. And we also needed to know post-pandemic, what was the knowledge in our health and social services. So we did an informal survey, and we found out that the 2-on-1 was underused from the part of the professionals. And there was a need, as Elaine said, to have a platform or resource directory with updated resources from the community. So all of this led us to start working with healthcare professionals, with the community as well, to create this. And our objective really is to sustain and integrate Click Social into a sustainable pathway that will stay alive even after this project, and that would enable a continuum of services for vulnerable populations, and that would bridge a certain gap between the healthcare services and creating in order to create a holistic care for people. So we really wish to make successful integration and try to make Quebec at least an example of how we can all work together. So next slide. So the online platform, as I said, facilitates social prescription by linking people in need with social resources. So we determined a couple of social determinants of health. We did not want to make it too broad or too narrow. So the point of Click Social for me is to co-construct, to create something that is co-constructed by healthcare professionals and community workers, and we want it to be easy to use. We also want Click Social to be able to help create a prescription that is co-constructed with the prescriber and the patient together. So putting the patient in at the front and center of any intervention that we're going to create. We also wanted to be able to permit follow-up so that it becomes ingrained, and then we can see if the referrals or the services that we offer are up to par to the needs of that person. And we also wanted to create that directory that allows us to look for services depending on social determinants of health, the age group, population group. And by that, I mean a certain population that needs a specific service. So for example, if that population is a newcomer, then that would be, you would be able to find a service associated to that. And as well by location. And location is really sub-territories or neighborhood in the Montreal area. Next slide. So I'm going to show you a little video of Click Social in action with my voice narrating a little bit of a tour for this. So I'm going to share my screen link. And there we go, share. Hopefully you can see it. I'll put it in full screen and play.
Welcome to Click Social. Click Social is a community-based initiative inspired by the concept of social prescription. Social prescription is the concept of allowing an open communication towards the needs of any individual and creating a personalized referral, accompaniment, and follow-up towards the appropriate community service. Becoming a social prescriber is as easy as signing up. Once you are a social prescriber, you will be able to log in and gain access to your profile page and our online resource directory. Your profile page allows you to be identified as a social prescriber. It will help individuals receiving social prescriptions to know who the social prescribers are. This will encourage better communication and follow-up between the referred community organizations and the initial social prescriber. You will also notice on your profile page 3 shortcut tabs which are necessary to create a social prescription. As such, the first step in creating a social prescription implies the creation of a client profile. The Client tab is your personal directory of the clients to whom you have created a social prescription. To create a new client profile, you must click on the Add Client tab and fill in their name and last name. For your statistical purposes, and with the consent of your client, you may also fill in the social demographic information below. Note that you can create an anonymized client profile which will generate a blank social prescription. Once you are satisfied with the profile you have created, you can add it to your directory by clicking the Confirm button. The shortcut buttons on the right of each name allow you to edit or delete the profile as well as consult all the social prescriptions created for each client. The shortcut button with the shape of a plus sign lets you immediately create a social prescription under a client's profile. Alternatively, you can create a social prescription by navigating to the tab called Prescriptions. To create a prescription, simply click on Add a Prescription and choose the correct client. Modifying your motivational text to encourage your client to address the social determinants of health for which this social prescription was created is also recommended. To find a community organization, you can use 4 filters. Those filters are category, age group, determinants, and territory. You can select as many tags as you wish per filter and specify if you're searching for both tags or either tags. You can also use the search bar to look for a specific organization or service using the title or description filter. Placing your cursor under the information icon allows you to see the services offered by each organization. Clicking the Add button adds the organization to your social prescription. Adding additional information to specify which services you are referring to or to add relevant information to help the client smoothly access the service is also recommended. Clicking Confirm will create the social prescription. You may consult past prescription notes at any time using the Prescriptions tab. You may also see the social prescription itself by using the PDF shortcut. You can also delete any social prescription by clicking the Delete button. Some additional features to Click Social include a resource map and your social prescribing statistics. Clicking the Resources tab will redirect you to an interactive map which allows you to see the community organization within each territory. This map also allows you to filter the organization per social determinants of health. Clicking on the Dashboard tab allows you to view the statistics, such as what tags you use per filter to create your social prescription, and the overall social demographic spread of your clients. For further assistance, comments, or to report any type of bug, please select the Contact Us tab. Thank you for using Click Social and for helping us be the meeting point between healthcare professionals and community workers.
Oh, there you go. This was a quick overview of our platform. Of course, it is a work in progress, and it will be changed depending on the feedback that we get and depending on the needs of our community and healthcare professional partners. So for our implementation plan and for basically all the work we're going to be doing following this, we are currently collaborating and co-constructing Click Social with us and the community and the CS Centre-Ouest, so our health and social services partners. We are trying to do some outreach, increase awareness, and expand the service of the database. By increase awareness, I mean increase awareness of this project and the needs that are associated with it that we're trying to address. We also want to identify an intuitive referral system that would permit us linking all of the sectors together. We also want to create a team of link workers or navigators that reflect the needs of the population, the reality as well as of each borough and of Montreal. And we are currently trying to do another pilot test very briefly to see the prescriber's experience, the referral pathway without navigators for now, and to be able to expand upon what the platform needs if we're doing a straight referral, and what should we look for a link worker. And we also want to have this user experience and to identify key identifications for success. So back to you, Elaine, I think. You're on mute.
Apologies. Thanks a lot. I'm going to take you now through a series of slides that describe some of the preliminary results of our implementation research activities. Oops. Okay. So, so one area of work that we've been focusing on is really understanding the situation with respect to community organizations and service users. And in this particular instance, we focused on older adults as our use case. So our objectives here were to assess implementation challenges in terms of the delivery of community-based services that address social determinants of health for older adults, to explore some of the challenges that older adults experience in accessing appropriate community-based services, and then to identify opportunities and strategies to improve the accessibility and the delivery of needed community services for older adults and their connection with the primary care system. So we first looked at community organizations and interviewed 8 service providers from 6 community-based organizations in total. And this work, I should indicate, was undertaken by one of our students, Katerina. And there were a number of kind of key findings that emerged from these interviews. So one was the overall, sorry, it wasn't Katerina, it was Katrina. Apologies, Katrina. So one finding was that there was very strong support for social prescribing from community service providers. And they saw this as a very important means of ensuring that community services are available to those in need. They mentioned that good assessment is critical for linking clients to appropriate services. Sometimes they receive clients who have needs that can't be addressed or managed by the organization. And thirdly, they stressed the importance of informed referral for facilitating access to services. They explained how referrals from primary care may exceed, in certain cases, the organization's capacity to respond, and thus discouraging people whose needs may go unmet. Services may be overstretched. Services may also have limitations in terms of the numbers that they can accommodate, the timing of those services, that there may be membership requirements. Important to know these in advance to avoid wasted effort and frustration on the part of the older person or the client. And then we looked at older adults' experience with service access and utilization through interviews. We conducted 17 interviews with older adults attending 6 community-based organizations. And this was a piece of research which was conducted by a student, Ekaterina. So key findings here was that social isolation, interestingly enough, was a major reason for seeking community-based services, especially among those who identified with having disabilities. And other reasons included needs associated with low income, support for disability, and a desire for belonging, contribution, and physical activity. Major barriers to participation were physical disability and experiences of ageism, which was very interesting. And as well in Montreal, language barriers were very important. In addition, not having many people, the same gender present in activities that was mentioned, or missing activities they once enjoyed prior to the COVID-19 pandemic, but which were not renewed post-pandemic. A large group of students, led by Catherine Paquette, who's on the screen, organized a scoping review to map and synthesize current knowledge on known factors that influence community-dwelling older adults' awareness, access, and utilization of non-medical community services. Approximately 4,000 articles were screened, and 92 were identified as being relevant. A wide range of factors were identified, and they're sort of displayed here on the screen in very fine print, but I'll go through some of them. With respect to individual characteristics, factors associated with greater use were socio-demographic factors such as education and a better financial situation, being female, and also younger in age. Other factors associated with greater use were individuals who had greater needs, such as those with chronic diseases, lower functional capacity, and those who were socially isolated. Facilitators were having access to someone for transportation and living in urban areas. Key facilitators related to the organizations or the services they offer included easily accessible services in terms of distance, transportation, and cost, having more services and resources, awareness of the organization and their services in the population, and then also providing inclusive and high quality services. These all facilitated the use of services. Other factors were identified that pertain to individuals acting as intermediaries between users and services. These included health professionals and carers. A few barriers were identified for health professionals, specifically the lack of knowledge about available services and the lack of appropriate evaluation of needs. Carers were seen as having the potential to act as a bridge between users and services, but were also seen as a potential barrier by trying to compensate or replace the services available in the community or not being aware that such services exist. Finally, a few barriers were identified at the societal or policy level, and these included lack of coordination between health professionals and community organizations, lack of centralization of information about existing services, and lack of flexibility regarding the use of governmental financial assistance. So this research, I think, was very useful in reviewing and highlighting some of the key barriers that need to be addressed through the implementation of a social prescription program, and interestingly, were reflected in a lot of the primary research we've been undertaking as well. One thing that became very clear is that understanding current health provider attitudes and behavior regarding social needs assessment and referral is a very important step in advancing social prescribing uptake. And so we did a number of activities with health providers, actually outreach activities, which we conducted, as I mentioned before, in the context of grand rounds and regular team meetings. We had four main goals. First, to assess the existing knowledge of providers with respect to social prescription, to explore what they're actually doing, currently with respect to social needs and referral of patients with identified social needs, and what those practices are and challenges associated with them. We wanted to inform them about social prescription practices and stimulate interest in this idea of building a pathway, but also interest in using the Click Social platform, which Paula demonstrated. So we used outreach sessions. We had 6 of them and incorporated some polling questions within those sessions. And we also conducted deliberative dialogues with providers to really dig a little deeper with respect to what are the components of a feasible social prescription pathway, with respect to their views of what might work in their primary care practice. So interestingly, it became very clear that providers play a very active role in addressing social needs within their practice. The large majority of clinicians primarily relied on their clinical experience to detect social needs. The 3 most frequently sort of named social needs that they claim to see in clinics included housing insecurity, social isolation, and immigration and legal challenges. And these things changed across clinics because different clinics are serving different populations. But one area in particular, immigration legal challenges, were extremely important. To address these needs, physicians often refer patients to another provider or refer their patient to a community resource or service directly. For some primary care providers, assessing and attending to the social needs of patients is really beyond their scope of practice or their capacity in the context of time-limited clinical encounters. Other observations included concerns about incomplete and out-of-date lists of resources and activities and services in the community, the absence of laypersons tasked or trained to perform link worker functions were also mentioned in several instances. Concerns also about accountability and responsibility when referring patients to non-medical services. So, we see that, understanding current provider attitudes and behaviors regarding social needs assessment and referral is really very, very important if we're going to make this work in our setting. We also, so in terms of the deliberative dialogues, just to say, this was a new method for me. I first conducted a deliberative dialogue during the pandemic, but it is a structured conversation that leads to a collective decision on a given subject, and it's based on evidence. So what you do is you present evidence to a group, and they deliberate in a very focused way to come up with some type of solution or recommendation. So in our case, our deliberative dialogue's goal was to identify a few feasible and potentially high impact actions for implementing social prescription in primary care practice. And we had two guiding questions. First was, based on your experience, what are the top barriers to social prescription, and what from becoming a reality for you and your patients? And the second one was to meet your needs as primary care providers and those of your patients. What would a functional social prescription pathway look like from the assessment of social needs to connection with resources? So we had 6 primary care providers in our deliberative dialogue representing physiotherapy, social work, and family medicine. It was a very interesting conversation. And I will present some of those findings now. So in terms of barriers to implementation, again, a lot of the same sorts of things came up. Issues in their view about lack of clinician time and interest. Concerns, and this is particularly true in the Quebec context, about bureaucracies being too complex to accommodate social prescription. Lack of clarity about who might play that role of link worker or facilitator connector. Issues around language and culture, and the barriers those often sort of place in terms of access. Concerns particularly about people who are under the radar, who just don't, whose needs go unspoken. So this is very important, trying to think about ways to offer these services in multiple languages. Out-of-date lists and poor quality of services. You don't want to have poor quality service on your list, but that needs to be assessed on a regular basis. Insufficient capacity of community organizations to receive patients. This is certainly the case currently with respect to some of the food banks that are serving Montreal's food insecure communities. Systems overload without evidence of effectiveness. Again, the importance of research here and generating evidence of impact. And then insufficient clarity on how community organizations can refer back to the health system. So that's being a very important part of the pathway that needs to be worked through. So then we asked them, so what are some of what are the minimum specifications? So for referral only, let's just dig deep in terms of referral and what that might look like. And what they emphasized was the importance of having some kind of assessment of needs. And we have been exploring this through another piece of research, looking at different sort of tools and deciding, which ones might be best sort of or most appropriate for the purposes of social prescription. Something that isn't too extensive and tiring for an individual to kind of reply to, but something which is sensitive enough to identify what the crucial needs are. Translation services were something they felt was very important to facilitate referral, and then access to a link worker or facilitator for self or supported assessment referral as well. This kind of individual who's sort of a backup or a person who you can sort of ask a question to or get some support from is very important. Up-to-date lists of services with eligibility for those services, basic information on the person who's being referred to the receiving organization, with feedback provided to the healthcare provider themselves. So this idea of a loop of information flow being something they feel would be extremely important in the referral process. They emphasized that the speed of intake of new patients into these services has to be has to be reasonable. Otherwise, what happens is you begin to compromise the credibility of referral. So again, community-based organizations need to be able to pick up those who are being referred in a timely fashion. And then finally, emphasis on the importance of learning and adaptation in terms of any system which is put in place, that it will be a matter of iteration before one gets it right, and always context changes and adaptations have to be made. Oh yeah, sorry. This slide was misplaced, but this is the social needs assessment I mentioned that we had done. We looked at different key domains of social assessment and measures, and found 56 tools in multiple languages, many of which can be integrated into electronic health records. Food insecurity and housing seem to be the most common domains assessed across these tools. Still a need for psychometric evidence on their sensitivity. And then the 3 tools listed below, Repair, Seek, and Sincere, seem to be well suited for social prescribing. So our next steps, we are collaborating with our local health authority, the CIUS Centre-Ouest, and our community-based partner, Eva Marston Center, around the co-design of a feasible social prescription pathway for several distinct contexts. Primary care practice, idea of putting this in the context of telephone referral system, which is in place for patients with no family doctor in Quebec, but then also placing this in area-based social service agencies as well. And looking at these 3, models or modes of delivery, and perhaps using an RCT to measure impact. In terms of, I think what we've learned through this process, first to emphasize the importance of implementation research to feasible intervention design. This knowledge that we've gained through applying the consolidated framework for implementation research in particular has been really helpful, both in structuring our formative research and in terms of the kind of information that it has yielded. Just very briefly, for those who aren't familiar with this implementation research framework, the outer setting is really sort of looking at attitudes, local conditions, partnerships, and financing for social prescription in our case. So to really understand what the context, that broader context is. The inner setting is where you start looking at what are the practice settings looking like? What are the incentives in place to enable a social prescription to be taken up in a sort of a reasonable way? The culture and relational connections being very important, and the relative priority to this as well. It's not going to work unless it's given priority. And then looking at the individual level, understanding the roles of the different sort of stakeholders within the system, in the healthcare setting, those practitioners, in community-based settings, obviously organizers, as well as those who use these services. All of those experiences and viewpoints are important to assess. And then project characteristics need to be considered, and including capability and motivation of those delivering social prescription. So very valuable framework that does help in structuring research and also sort of thinking through all the dimensions that are necessary to build and co-design a feasible social prescription pathway. Just a few other last thoughts. One being about the value of partnership. As a research organization, Laval and McGill have been working closely with the Eva Marston Center over the last couple of years. And that's been incredibly valuable in terms of the questions that we ask and our approach in terms of asking them. In working with both community-based organizations and with clinical practice settings, the value of outreach can't be emphasized enough. Getting into these settings and discussing and creating that engagement and buy-in. And finally, the importance of evaluation as a means to demonstrate effectiveness. This came up several times, and is something we will incorporate into our research sort of moving forward. So that is all from me. I think we have some time for discussion now. So if there are any questions, please ask them.
There are some questions in the chat, Elena. The latest one is regarding your publishing. Have you published yet?
So this is a really good question, and it actually kind of relates to my sort of values as a researcher. I'm not a person who sort of feels it's important to sit on results before sort of sharing them, especially around something as important as social prescription. So yes, things are in the works, but not published yet. But we are sharing our preliminary results because we think, these are useful sort of insights that others could benefit from. Okay, Paula, can you continue to help me with questions, because I didn't see any of them.
All right. The next question is regarding our email address. If we would be willing to share them. I suppose
Okay.
that is a yes.
Absolutely.
Share more about Prepare, Seek, and Sincere.
Oh. So those are I'm not going to really be able to give you details on those, because I haven't looked at them in great very extensively myself, although one of our students has, and she was the one who reviewed these 56 tools. But search them out. We can certainly give you links if you put your email in the chat, and direct you to them. Catherine, do you have anything to add?
No, I think, sorry for my voice. I think they were selected based on specific criteria in terms of adaptability and, availability in different languages. And, there was, I don't know, many factors she looked at. So that's the reason why these three stood out, because they were meeting most of these criteria. But yeah, we can definitely send the links to anyone interested. Paula, there was also a question about you answered already, and I answered the question already. So we're very efficient.
Yeah. Yeah, there's one. Oh, so you did reply to Ivory. Thank you, Catherine. I see that. A few new messages.
Will we have access to the PowerPoint? Oh.
Sure, we can sort of make those available. I see here, have you found Canadian social needs assessment tools you like? So it'd be interesting if there's somebody in the audience who's been involved, and I know that there's been, I think it's, is it Spark? Is that the Canadian tool which is being developed? It's an adaptation of Prepare, I think. And so I'm eagerly awaiting this tool and its release. But I think they have been the folks who've been sort of working on that have been careful about thinking through what sort of specific sorts of issues need to be incorporated in a tool that is appropriate for our Canadian context. I don't know whether anybody in the audience can speak to Spark at all. It'd be very interesting to hear where it's at.
I guess not.
Okay. I again, I think if there's anybody who wants to share how they are engaging research in the context of the rolling out of their social prescription projects. I'd be really interested to hear about those experiences and the sorts of things that you're thinking about in terms of evaluation. That would be, I think, extremely valuable for the group if you'd be willing to share. Suffice it to say, I think because social prescription is really, as I mentioned about, at the beginning of the presentation, in its infancy in some respects, and it will necessarily look very different than it does in other parts of the world. We don't have a lovely sort of uniform national sort of health system like the UK, and so it will necessarily be the case that it looks different across our provincial and sort of territorial jurisdictions. But in that context, the importance that we do all this due diligence in terms of really understanding that context and understanding the needs, engaging stakeholders from all sectors, and really, moving forward with something that seems a reasonable place to start. Unlikely that we'll get it right the first time, but hence the importance of really studying process through sort of research and learning, from that evidence and reflecting on it and figuring out how to improve, systems of delivery. That is absolutely critical, and I hope we all heed our sort of experience and advice about its importance. Engage research groups in rolling things out, because I think it will be very helpful in the long run in terms of moving indicators in the right way and meeting those social needs and addressing the social determinants of health, which we know are so critical in terms of health outcomes. Do you have anything more to add, Catherine? No? Paula, anything from you?
I think I would add that I'm not sure who is in this presentation, if we're community workers or if we're doctors or whatnot, but I think the importance of collaboration with universities, with people who are interested in doing that research for you, is really important. And from a community perspective, it gives us a little bit of credibility, and it helps us as well to be able to evaluate something as not sure for any of you, but we usually implement and we struggle afterwards to see the impact it actually has. We can ask our clientele usually if they were okay with the services or if they need something else, but it's not concretely evaluated. And the next question is, I'm wondering if you would expect the barriers you identify to differ based on rural, urban context. And she missed Megan missed the beginning, and she apologizes if this was discussed already.
Well, it wasn't actually discussed specifically, because our work has been and at least will continue to be urban focused for the moment. But no, I think there'll be very substantial set of differences in terms of some of those barriers. That and again, not to sound like a broken record, but I think it is important to understand those contextual level barriers well in design, because they will be quite particular, I think, depending on context and population as well. We noticed in our sort of work with outreach with different clinical practices that the demographics of the populations they serve are very distinct, and the issues that those populations are experiencing are very distinct. Some serve, a slightly older population. Others are sort of located in communities where there are, high concentration of South Asian immigrants, many of whom are fairly new and not familiar with the complexities of Quebec's health and social care system. So it is important to do that due diligence with respect to setting and understanding it.
if I can add something from the literature we reviewed, we definitely, there was a number of studies identified being in an urban environment being associated with greater odds of using services. And I think the reasons they were proposing is that the distance that needs to be traveled to access services in non-urban regions would be higher, which would be one of the barriers. And also there's less options in terms of the services available for these populations. So yes, they would definitely differ.
Mm-hmm.
Yes, and to add upon that, I know that some in rural parts that I've had the chance to talk to, they might also not need the same type of intense intervention or as we do in Montreal, as perhaps they're very well connected with the health and services sectors. It depends on each place, and there is another question.
Yeah, so Sebastian asks, the social prescription programs for older adults experiencing isolation and newcomers learning English or French that are running or ran. And I just to say, it was really interesting when we were doing outreach with community-based organizations and networks of community-based organizations, this eureka moment for some of those groups, particularly those working with older populations. Oh, well, we're doing social prescription, they said. I never knew what to call it, but it's social prescription. So yes, there are organizations in the Montreal area that offer, a range of holistic services for older adults. I think what's interesting, though, a number of organizations did say to us that they don't feel that they necessarily get in their doors the populations that most need their services. And this is where I think the value of that kind of feedback loop with primary care becomes very important, because some of those individuals that fall under the radar, the socially isolated sort of older person who hasn't, necessarily the agency to go to a community-based organization for older adults on their own initiative, may well go to their doctor and it becomes very clear that they're isolated and lonely and could benefit from linkage with an organization like that, but just require a little bit of a helping hand to make that connection. So I think this is the value of that linkage between primary care and community-based organization that I think is really worth figuring out in terms of its functioning, feasible functioning. There's another question about social isolation or social prescription for educational institutions, and whether we're familiar with any initiatives to address that. I don't know anything myself to recommend. I'm sure there are some initiatives somewhere, but please, if you know of anything for Augusta, quickly put your link in the chat. Mm-hmm.
Yeah. Very quickly, in Quebec, I don't think there are, but it's not called social prescription. There are a few initiatives in that sense of breaking social isolation for seniors, but it's not called social prescription. I think we are one of the biggest network in our region. And for the filters, I don't have a filter for homebound individuals. But if the needs are met, well, if there is a need for that, we would add that filter. And the next question, I believe, is for social isolation for students, if you're familiar. So that's the thing you answered, right? Okay.
So if anybody has something to share on that front, please sort of indicate that in the chat. One thing that, it did come to mind, though, and that came up quite often, was this issue about disability, and this being a big barrier to care among older adults. So this could be something that needs to be, obviously assessed in the context of a social assessment, but also, potentially some kind of filter within the platform. The platform, continues to adapt and evolve, and recognizing that as with use, it will necessarily need to respond in ways to make it even more user friendly and even more intuitive for people using it. Okay, so thank you very much for your participation and your attention. We're really grateful for your time and promise to publish soon. So thank you very much.
Thank you very much.